Today, I wanted to continue our conversation about eye movements, and we looked at the anatomy of the extraocular muscles, how they travel from the apex of the orbit towards the eye, and how they rotate the eye. So today I'm going to talk about things that go wrong. So we have looked at the 6 extraocular muscles operating the eyes, and you may see in some of the textbooks that there are pictures of the eye, and it looks rather like this diagram here, where the eyes are in 9 positions. So we have 3 across the top, 3 across the middle, 3 across the bottom. So we call this the 9 diagnostic positions of gaze. So in the primary position, we're looking at eyes that are straight. So there's a corneal reflection from the flashlight, and it's looking symmetrical in each of the pupils. When we're testing the muscle actions, we ask the patient to follow a target. So in the example, I'm moving my cursor to the patient's right. So when we ask the patient to follow the target to the right, we're testing the action of the muscle which works maximally to abduct the eye. So the muscle which is the main abductor is the right lateral rectus. And the left eye is having to move inwards towards the nose. So we call that adduction, adduction. And the muscle which makes the eye adduct is the medial rectus. So when we ask the patient to follow the target into the right gaze, we're testing the power, the action of the right lateral rectus and the left medial rectus. And we know from experience that those muscles work together, although they're not driven by the same nerve. The 6th nerve is the nerve that operates the lateral rectus, and the 3rd nerve operates the action of the medial rectus. So I'm going to talk about conditions today where the nerve stops acting. The nerve is damaged, or it's inflamed, or it has a tumor pressing on it, and so it stops the messages going to the muscle, and therefore the eye doesn't receive the messages and it doesn't move. If we just go over the same lateral movement horizontally to the other side, when the patient is asked to follow to their left side, we're looking at the action of the left lateral rectus and the right medial rectus. So those actions are the simplest to remember because we looked at the graphs for the power of those muscles, and 85% of the power is in the horizontal direction. So they either adduct and abduct. They don't have very much torsional power, they don't have very much vertical power. When we ask the patient to look straight up, we're testing the action of the strongest elevating muscles. And the strongest elevator by far is the superior rectus, although the inferior oblique does have some elevation power, but it's not as high a percentage of its total as the superior rectus. So one eye may be defective if the power to that muscle is not working properly, and we would be able to see that this eye was not moving and the other eye would be moving more. So in my example, everything is symmetrical. They're both moving up by the same amount. You can see the white part underneath the eyes. So they are both elevating equally. When we look up to the patient's right, so we need to remember that we're facing the patient. This is the patient's right eye. This is the patient's left eye. So looking in this position, we're looking at the patient's right side. They're looking up to their right. And we call that dextro, if you want to use the Latin term. So you may find in the textbooks it's called dextro elevation. So I talked last week about the fact that the superior rectus is inserted on the globe at an angle of 23 degrees. So when the eyes are moved outwards, the elevation becomes the most powerful action of the muscle. So to find out if the superior rectus is working, we want to find out in its area of best action, its area of maximum action, whether it's elevating the eye fully. And at the same time, in the left eye will also be elevated partly by the superior rectus, but also by the inferior oblique, because the more the eye is adducted, the more elevation power the inferior oblique has. So when we're looking in the diagonal positions, when we're looking up to the right, we call these two muscles that work as a pair, we call them synergists, or we call them yoke muscles. So whichever name you find most easy to use, you can use. It's either yoked together or it is a synergist. They work together. The mirror image happens looking up to the patient's left, and the Latin for left is levo. So up to the patient's left, we can see that there is a superior rectus, main action in slight abduction of the eye, and the yoke muscle, the synergist to the superior rectus in the right eye, is the inferior oblique. Now you may remember that I said it's a bit confusing with the obliques because it's an inferior oblique because it's anatomically on the underside of the eye, but because it's inserted behind the rotation of point of the eye, it actually elevates the eye. So anatomically it's inferior, but the action is to elevate. Looking down to the patient's left, so we've got now left or levo depression, and we have got the eyes slightly abducted by 23 degrees. So we're looking at the main action of vertical, and in this case the inferior rectus is the main depressing muscle. So we're looking at the main action of the inferior rectus of the left eye, and the yoke muscle in the other eye is the right superior oblique. So superior oblique because it's anatomically attached to the top of the eye, and you remember it comes through the trochlea on the nasal side of the eye, but it rotates the back of the eye up and the front of the eye down. So it is actually a depressing muscle. When we look straight down, we're looking at the main action of the strongest depressing muscle, which is the inferior rectus. And when we look to the side in dextrodepression, we're looking at the main action of the inferior rectus. Now the eye is abducted by 23 degrees, so it's in line with the axis of the muscle. So it's the strongest area of depression. And the superior oblique, although the main action is torsion, the secondary actions are depression and slight abduction. So the 9 positions of gaze, you can use the term right elevation, or you can look in the textbooks. Don't be confused if it says dextro elevation. So these are the 9 positions of gaze that we talk about, and that's how we test eye movements. We do the cover test in the primary position, and then we do the cover test looking in each of these 9 cardinal positions. If there's no muscle weakness and no muscle palsy, whatever phoria or tropia you find in the primary position should stay the same in each of the 9 cardinal positions of gaze. and we would call that concomitant. That just means that the squint stays the same wherever you look. If one of the nerves is damaged or the muscle itself is damaged, then something will change. Either the patient gets double vision when they look in a certain direction, or you will see some kind of limitation of the eyes. And so testing is done in 9 positions. This is quite a common illustration from a textbook, which you might find. So the same as in my diagram, but I had a real life patient. In this diagrammatic form, we've drawn the eyes. So again, this is the patient's right eye. This is the patient's left eye. So it's representing that this is the nasal puncti. And we're looking at the patient looking up to their right. So this is dextro elevation. And we're looking at the action of the right superior rectus and its yoke muscle, the left inferior oblique. Same, looking to the right, looking to the left, looking down to the left, looking down to the right. So you'll see these abbreviations in all of the diagrams, and it's useful to use the abbreviations just for shorthand, and also if you're entering it into a computer or if you're using an iPad, it's much easier to use abbreviations than to have to write the whole word each time. So we usually use these abbreviations for each of the muscles. So just to reiterate what I said about the obliques, these are the funny ones. So the superior oblique is on the top of the eye. It comes from the annulus of Zinn, comes forward along the nasal wall, and then it bends backwards through a cartilage socket, and it goes backwards as a tendon to behind the center of rotation. So the superior oblique, because it's at the back of the center of rotation, it's going to rotate the eye downwards. And the inferior oblique, it's the only muscle that starts on the medial wall and travels underneath the inferior rectus towards the lateral rectus, and it inserts behind the center of rotation. So when it contracts, it actually elevates the eye. So these obliques are the funny ones. They start nearer the nose, and so their actions don't help by their anatomical name. You just have to remember that the superior oblique actually depresses the eye and the inferior oblique elevates the eye. When we're diagrammatically representing our findings from testing the eye muscles, we use a diagram for each eye separately. So we use the diagram for the right eye and the left eye as we're facing the patient. So we're looking at the patient. This is the patient's right. This is the patient's left. And we discussed last time using a number system to show which is the eye which is most affected on a scale of 0 to 4. We remember that there are main actions and tertiary actions. So the main action of the superior oblique is to intort. The main action of the inferior oblique is to extort. So if there is damage to either of those muscles, the patient will describe double vision with the images tilted. So this is characteristic of a palsy of the obliques. The muscle obliques also have a slight abducting effect, but it's very weak. It's not the main action. The superior rectus and inferior rectus are our prime elevator and depressor muscles, but they too have secondary actions because of their insertion on the globe. So their secondary action is adduction, and they also have a slight in-cyclotorsion of the superior rectus and ex-cyclorotation of the inferior rectus, but by far the least percentage of their actions. So we decided that we would be comfortable using the scale that you often see in textbooks or in literature. If there is normal movement of the muscles, it's a scale of 0. If there's underaction, if there's a defect, It's either 25% missing, 50% missing, 75% missing, or 100% missing. So this is a total loss of function. Whenever you have two muscles working together, they're going to be yoked, as I said, or they're synergists. And so for every underaction, there will be an equal overaction. So if you have a -1 underaction of one muscle, the synergist will overact by an equal amount, as a rule, not 100%, but as a rule. So we have -4 indicating there's no movement beyond the straight ahead, as in there's no function left at all. That would be a total paralysis. Or if they even can't reach the midline, we do use -5 sometimes. There will be overaction of the muscles, which are the synergists, and the maximum overaction would be indicated as +4. So here is an example of a patient with a possible superior oblique underaction. This is the diagram of the right eye, the diagram of the left eye. So we would indicate in the area where the superior oblique should be working that there's an example here of -3. So 75% is missing. They've only got 25% left of their action, of the superior oblique action. When they look to the side, this eye may start to rise. So we have an arrow indicating that this eye starts to go upwards. And there may be an overaction of the antagonist in the same eye, which would be the right inferior oblique. So just to get you orientated, this is the patient's right, this is the patient's left. When we're indicating our muscle actions, we're looking at two eyes. So when there's a superior oblique underaction, you would also see an overaction of the synergist in the other eye, which would be the left inferior rectus. If there is complete inability for the eye to move, we sometimes use this, what we call hatching or line diagram. So it's hatched. So in this example, we've got a blowout fracture. That means that the patient has had trauma to the left eye, and the eye can no longer look up and it can no longer look down fully. It's not symmetrical, so the limitation of up gaze is greater, it's -3, whereas the limitation of down gaze is only -1. And because it's mechanical, it's happening when the eye is looking in and when the eye is looking out, and it's due to the muscles being trapped in the floor of the orbit. So we have underactions indicated as minus, and we have the synergists in the other eye overacting, and they're indicated as plus. If the eye will elevate once it's covered, we call this an underaction. And so that we don't put stripy lines on, because when we cover the normal eye, this one will elevate, but with effort. It's going upwards because it's overacting, and it's not going downwards fully. But it's not limited. It can actually move down when we cover the fixing eye. And I hope to show you some examples of that when we see your patients. You can actually describe the muscle underactions if you want to use English words, if you want to use abbreviations. But on the whole, most people find drawing diagrams quicker and easier, and you can then pass the information from one colleague to the next and understand what you're meaning. So a description here of moderate underaction of the right eye on dextro elevation. Instead of that sentence, we've just put -3 in the area of the action of the right superior rectus. Right elevation, dextro elevation. The second sentence, overaction of the left eye in dextro elevation, is again looking up in the area of the inferior oblique. So we've got overaction and we've put +3. And there's also an updrift of the left eye in dextroversion. So that's this arrow. So the arrow indicates that the eye is starting to elevate even when they look straight across into dextroversion. And you may also see these lines which are representing A or V patterns. We'll go into that at some later stage, but it means that the deviation is wider at looking up. So either there's an exo deviation looking up, bigger than looking down, or there's an ESO deviation which gets less looking down. So that's a V pattern. So we're looking at ocular motility defects today, and they can be from birth or soon after birth. So they could be actually formed during gestational periods in the 3rd trimester. For example, Duane's is thought to occur when the fetus is developing. Or it could be immediately after birth, or they could develop hydrocephalus in the first few weeks of birth. So by congenital, we're really meaning in the first few months of life. And it can be acquired later on in life. It can be acquired at any adult age, and so therefore it would have symptoms of double vision. If it's congenital, the patient usually doesn't notice the double vision. So that's one of the differential features. It can be damage to the nerves. So we said that there are extraocular nerves which supply the muscles. The 6th nerve supplies the lateral rectus, the 4th nerve supplies the superior oblique, and the 3rd nerve supplies most everything else. In childhood, the most common reasons for damage to those nerve roots or the nerve centers, the nerve nuclei in the brain, would be the 3 T's: trauma, temperature, and tumor. So we call that the 3 T's. In adult life, paralytic squint again could be due to trauma to the head, to the eye itself, or to the back of the head, which would cause a 4th nerve palsy. Most common in unfortunate in our society where we have a high incidence of diabetes, we have quite a lot of muscle palsies due to diabetes, due to embolisms or vascular changes around the nerves or the nuclei in the midbrain, and hypertension and inflammation, especially things like multiple sclerosis. Mechanical issues, we call those where the eyes are stuck, so they don't improve when you cover the fixing eye. So that would be when we were using the shading. So we gave you the example of the blowout fracture on the previous slide. It would also include thyroid eye disease, and also eyes which become highly myopic, which also start to become restricted and don't move smoothly. And then you can have conditions of the muscle itself. So fibrosis of the muscles can be a genetic inherited disease. You can have blepharophimosis, where the eyes are misshapen, and you can have hypoplasia of the extraocular muscles themselves. In adult life, diseases which affect the muscles would be myasthenia gravis, hypertonia, the wet phase of thyroid eye disease, chronic progressive external ophthalmoplegia, myositis, to name but a few. So if we have muscle palsies, patients will often come in with a characteristic head posture. So in this case, this gentleman is tilting his head. And he's tilting his head because he has a vertical muscle palsy. And by tilting his head, he gets single vision. This patient doesn't need a head posture because he has a ptosis and he doesn't get double vision. but obviously something has happened to the nerve which is going to his levator. So the nerve supplying the levator, palpebris superioris, the iris, the ciliary muscle, the medial rectus, inferior oblique, and superior rectus is the third nerve. The nerve which supplies the vertical muscle, which would cause the eye to become hypertropic and the patient to adopt a tilt, is the fourth nerve. And by far the most common palsy that we're going to deal with is the sixth nerve palsy. It happens most often, and therefore you're going to see quite a lot of this in your clinic. Just to give you examples of the mechanical types of problems, this patient has a Duane's syndrome, which she was born with. The right eye is fixed, it won't go outwards, so it has a -3 abduction deficit when the patient tries to look to the right. When the patient tries to look to the left, the right eye also cannot adduct, cannot adduct. So the patient is most comfortable when her head is turned slightly to the left, where she actually has binocular single vision. She's got an exophoria. And as this patient doesn't grow out of this condition, she will continue with this for the rest of her life, and it doesn't normally cause any symptoms. They don't get pain, they don't get double vision, and they very rarely get amblyopia because they're using their eyes together just with a slight compensatory head posture. Mechanical problems, I mentioned blowout fracture. This patient has had a road traffic accident, so he's got trauma he's got lacerations to the upper and the zygomatic bone and the frontal bone. He's got trauma, he's got conjunctival hemorrhage, and he's also got a blowout fracture. So he's got a zygomatic fracture as well. So that will cause a lot of symptoms, not only from the pain, but also they often get traumatic mydriasis, so they get blurred vision and they get double vision looking up and down. So that would be an example of an adult traumatic palsy. The children, I said, could have myogenic problems, and here is the characteristics of blepharophimosis syndrome. So they have the epicanthus inversus, the epicanthic folds are going upwards rather than downwards, and their eye muscles are very fixed, and they have drooping upper lids. So all of that is affecting the muscle fibers. And in patients with thyroid eye disease, the muscles, as you probably know, become inflamed. They increase in size by 5 times their normal volume, and the eye protrudes, it becomes exophthalmic, and the eyes in the wet phase become very proptosed, and then in the dry phase, the muscles become fibrotic and the eye can't move. So they have limited elevation, they have limited adduction and abduction. So it becomes very stiff and they have limited eye movements. So that would be an example of disease in the muscle itself. So I'm going to give you an example of a patient who's actually attended my clinic. This is a patient who came to the clinic. This was actually in the 1980s, so he's in his 50s, and he complained to his GP that he had double vision. So the GP sent him along to casualty, the casualty doctor sent him to the ophthalmologist, and the ophthalmologist diagnosed a sixth nerve palsy. So the history was that it started 7 days ago, so quite recent. And the double vision he noticed first of all when driving. So this is very common in a sixth nerve palsy because the lateral rectus is trying to move the eye out and keep the eye straight when you're looking far away. So often in a sixth nerve palsy, patients will say they get double vision when they're looking far away, and then it may become worse as it gradually, the double vision gets closer and closer to them. Now in his case, he's had this before. So he's had a previous episode of diplopia, he's had a previous episode of loss of vision in one eye, both of which resolved after 7 days. And then he had another episode 8 years later of double vision, which also resolved after 4 days. So this is a reoccurring problem. So we need to know what's going on with his general health. So the double vision, as described by the patient, can be horizontal, it can be vertical. So if it's horizontal, we're likely dealing with the medial rectus and lateral rectus. If it's vertical, if one image is above the other, then we're very likely dealing with a superior rectus or inferior rectus palsy. If the images are far away from each other, usually the patient can say, well, I can concentrate on the clearer one, and the other one, I know it's false, it's at the side. So they might shut their eye, they might put their hand up to their eye, or they may have patched their eye so that they don't see the double. But in the case of a sixth nerve palsy, the diplopia is worse when they're looking far away. So the diplopia image, when they're looking far away, may be far apart and easy for them to not ignore. But when they are looking close up, they could be close together, and that becomes more of a problem. So images that are close together or overlapping are extremely symptomatic. The patient really can't bear it. So they will often cover up one of their eyes with their hand or shut their eye in order to get rid of it. Images that are further apart are usually easier for the patient to tell which is the real one and which is the false one, and so they can just keep concentrating on the real one. But this is quite a debilitating symptom, and in the UK you're not allowed to drive a car if you've got sudden onset double vision. You can drive after 6 months if you've got used to it, and you can also drive with an eye patch. So we encourage patients to use an eye patch in order to get rid of the double vision. So we asked the patient about their general health, and this patient is diabetic. So they have high glucose. He's also on treatment for high cholesterol and for blood pressure, and he's taking a blood thinner. He's taking aspirin. He's also had some heart disease, so he's had some angioplasty for heart disease. So he's got past history of poor control of diabetes, and that's the reason why he's getting multiple episodes of diplopia. Looking inside his eyes, he's also got early lens opacities, which could be associated with the high glucose, high circulating glucose, but there's no obvious dot hemorrhages, no new blood vessels, and no macular edema. So he hasn't got full-blown diabetic retinopathy. But his visual acuities are reduced, and very likely that's due to the lens opacities. He doesn't have a history of any amblyopia or any previous eye surgery. So here he is with a small esotropia on the left eye. He hasn't changed his head position to try and make single vision, although we were able to tell him how to do that. And we actually said to him, have you noticed if you turn your head slightly, the images will join together. And it's very common that the esotropia will be small at near. So in this case, we've measured it with prisms to be 16 prism diopters when he's looking at 33 centimeters. And it gets bigger when he looks in the distance. And it also gets bigger when he fixes with the eye with the palsy. So underneath the cover, there's a bigger squint in the right eye, and we call this the primary and the secondary deviation. So it may change depending on which eye they're fixing with. So the maximum size was actually 30. So to draw his defect, we have done the eye movement examination, and this is how we can actually illustrate the defect. So the defect is happening when he looks into abduction, and we can grade it as being no abduction at all as -4, and the overacting synergist in the other eye would be given +4. Remember, this is the patient's right eye, this is the patient's left eye, this is looking to the patient's right, this is looking to the patient's left. And a written summary would be marked limitation, the left eye in all abducted positions. So that means looking over to the left. So here is an example of the animation to show limited abduction. So it means that we're asking the patient to look to the left. The left eye doesn't move fully. And even when we cover the right one, the left eye is still not abducting fully. So that is called a limitation. And that's when we use the hatch diagram. So in his actual example, he had the esotropia in the primary position, and he cannot abduct his eye fully, but I wouldn't call that -4. I think that's probably about 50% missing. So I'd be more likely to say that it was -3 or -2, but it is an objective qualification. It's just a percentage. So we're not measuring it at this stage. We can measure it with prisms in 9 positions of gaze, and we also have a Hess chart, which we use in the UK to measure. So looking to his right, his abduction is full in the right eye and his adduction is full. There's no vertical problems as he looks up or down. So remember that if the lateral rectus is not working, it's not going to be working in horizontal gaze, but it also can't abduct the eye when he looks up in dextro elevation, and it can't abduct the eye when he looks in levo depression. So levo elevation, I beg your pardon, and levo depression. So it's going to be present, that defect is going to be present in all gazes to his left. So thinking of the summary of what we've found so far, we have a case history of a patient who has general health problems. He's got diabetes, high blood pressure, cholesterol problems, and heart condition. He has had diplopia before. He's got an esotropia, he's got a convergent squint, which even if he hasn't noticed, then sometimes family members or friends will have reported it. His visual acuity, always ask if there was any childhood squint or any trauma, but this patient has diabetic early lens opacities. They may have already worked out that they can use a face turn in order to bring the double vision together. And if they haven't worked that out, one of the roles for the orthoptist is to tell the patient that they'll be much more comfortable if they turn their head. So in this patient's case, we did describe to him that if he turned his face to his left side, he would actually be able to see single vision again, because it would be away from the problem. It would be away from the left lateral rectus problem. When we did the cover test, we found an ESO deviation. It was smaller at near and bigger in the distance. And the diplopia is going to be uncrossed. And we can talk about projection and diplopia on another day. So the immediate symptom of double vision, which may prevent a patient driving, can be relieved by wearing an eye patch. It blocks out the double vision. It doesn't cure it. It doesn't make it work any quicker. It doesn't make it heal up. It doesn't make the muscle come back to work again, because the problem is the nerve. And you can't make nerves mend any quicker than they are able to do so. So you put a shutter over the eye. So I describe it that you're closing the shutter on your camera. Patients do get very anxious when you suggest wearing an eye patch because they say, oh, won't it make my vision deteriorate? And the answer is no, because your vision is fixed in your childhood. So apart from things like pathology that will happen, it's not going to degrade your visual acuity by covering it up now. So we can have a patch which goes around with elastic. You could make these locally. There's nothing technically difficult about it. And you can put one that goes underneath the pair of glasses, or we do have some which we actually fit onto the frames of the glasses. Obviously, it'd be good if they were washable, and you may have more than one if the patient needs to be wearing it all the time. So for this patient, he learnt to turn his head to the left in order to keep his eyes together so that he could see singly. We gave him a prism on his glasses for a while to help him feel more stable and secure, but it resolved after 3 months. So there was no treatment necessary apart from teaching him to live with his double vision. So if we think about other causes of sixth nerve palsy, I said that these problems can occur either at birth or during birth. And so we have got children with developmental problems, with cerebral palsy, spina bifida, hydrocephalus, where they have bilateral sixth nerve palsies, in which case they can't abduct either of their eyes and they have to turn their head. So he is actually looking at me at the camera with his head turned right round so that he can see across his nose. We can find children who unfortunately have trauma, who develop sixth nerve palsies, and you can get it after viral infections. So that's what I was saying about the 3 T's: the temperature, trauma, and tumour. We had a look at the anatomy of the extraocular muscles in the last lecture, and I want you to realise that those muscles are innervated by the nerve. So when the nerve is generated in the midbrain, it sends a message to the muscle to contract. So we have conditions which could affect the nerve in its course from the midbrain into the muscle. So things that will affect that muscle, that generation of that muscle, are trauma, tumours, and things like multiple sclerosis, where you're not getting the transmission of the nerve along the nerve fibres. In older patients, the most common problems would be diabetes and small vessel disease, small strokes, TIAs, or space occupying lesions, so tumours. So it is a complicated course, that nerve, and there are other issues that could happen to the sixth nerve, particularly if it just affects the nuclei, because the sixth nerve transmits nerve impulses to the third nerve in order to make the medial rectus work as well. So they work in pairs. So you can get other problems with conjugate gaze and other types of palsy where you get a sixth nerve palsy and other palsies together. So this is not just a simple diagram. It has multiple areas in which it could also get damaged and affected by other pathology. But I'm keeping it simple for today. So if what you're going to see in the clinic, I think, is going to be sixth nerve palsies. We've got surveys from different countries in the world, but a lot of the percentages are the same. The sixth nerve is a long nerve and it's liable to get damaged in several ways in several places. So you're going to see a higher percentage of patients with sixth nerve palsies than anything else. The second most common would be the third nerve, and the least common is the fourth nerve. In cases where they have a severe pathology, then you're going to get more than one nerve affected. So you might get a sixth and a third. You might be very unfortunate and get a sixth, a third, and a fourth. And you can get both on either side of the brain affected. So you could get bilateral fourth nerve palsy, bilateral sixth nerve palsy. And this is an intraocular problem where I said you get connections between the sixth nerve nucleus and the third nerve nucleus, and that can cause internuclear problems. So I want to talk a little bit about the sequence of events which happen after you've suddenly got this acquired palsy. And it's a sequence that we consider to be in 4 stages. If the palsy only occurs recently and it goes away within 3 months, as I have illustrated in my patient, you often only see the first 2 stages of the sequence. So in our example, we had a primary underaction. In my example, the gentleman had a left lateral rectus palsy. We would indicate that by minus because it's an underaction. And the opposite eye, the yolk or the synergist in the other eye, is going to overact because of the reciprocal and the Herring's laws that I'm going to just tell you about. Now, if the palsy remains for a few more months, or goes on for 6 or 7 months, or it goes on for a year, then the other 2 muscles in the actions of the horizontal gaze also get affected. So we have a series of under, over, over, under. And this is a pattern which you might memorize because of its sequence or visualize in some diagrams that I'm going to show you. But basically, you have an underaction, you have an overaction of the synergist, you have an overaction of the ipsilateral antagonist, and an underaction of the contralateral antagonist. So it is always going to be in this pattern, but it may not go all the way from 1 to 4. You may only get number 1 and number 2. And the reason that it's happening has been documented in laws of innervation. So the Herring's law and the Sherrington's law are the ways in which we have worked out what will happen and why it happens. So Herring's law is when there's a nervous impulse for the ocular muscle to contract, an equal impulse is sent to the synergist in the other eye. So when we have the left lateral rectus innervated, we're going to also get the right medial rectus innervated to make the eyes go to the left. So in order to look to the left, you need the left lateral rectus and the right medial rectus to be activated. Now, as you know from your biology, thinking about your legs, your arms, when one muscle contracts, you've got to have the antagonist relaxing. So you have to switch off the opposing muscle, otherwise nothing will happen. So when a muscle receives a nervous impulse to contract, an equal impulse is received to its antagonist to relax. So on the left side, looking to the left lateral rectus contracts, so it gets a plus, but the left medial rectus has to be turned off to enable the left eye to look to the left. So these are what we call the laws of innervation. Herring's is the equal innervation and Sherrington's is the reciprocal, the opposite. And again, for those of you that can memorize in patterns, it's going to be under, over, over, under. So we have a primary underaction of the left lateral rectus. We have an overaction of the synergist in the other eye, sometimes called the yoke muscle. And that's due to Herring's law. So when one muscle contracts, the other one is sent messages to also contract, and it's working normally, so it seems to work over. It overacts. As time goes on, stage 3 and 4, we have an overaction of the same eye, medial rectus, because it's pulling against a muscle which is now not working. And then the 4th stage is an inhibitional palsy of the other lateral rectus. So I've put this in the diagram. We've got a left lateral rectus underaction, and I've graded it as a 4, -4. So this is the primary underaction. So this is our number 1. Number 2 is the right medial rectus overaction. So because this one isn't working, it's getting lots of energy. The energy is also going to the synergist. This one's working fine. This one can't work, so this one seems to be working too much. As time goes on in the same eye, because this one isn't working and it's getting more innervation, this one also gets more innervation to relax, but it doesn't need to, so it seems to be overacting. And as time goes on, this one starts to underact because, again, there's nothing pulling against it, so it seems to be underacting. So this is a sequence, and it's due to the muscle laws of Herring's and Sherrington's, and it happens in this pattern, number 1 and 2 immediately, 3 maybe after a few weeks or months, and 4 again a bit later on. Nothing rigid about how many months. It can vary depending on the patient, comorbidities, whether they've had the condition before. So what I want to do in the chat, I don't know how many of us are with us at the moment, but I want you in the chat today to write down the muscle sequence for the 4 muscles that would be involved in the right lateral rectus palsy. So if you have a right lateral rectus palsy, what will be the 4 stages? What are going to be stage 1, 2, 3, and 4? Okay, so that's your quiz for today. And so to summarize what we've been talking about, we've got a patient who's got a muscle palsy and they've got an esotropia, and there could be marked overaction of the synergist in the other eye. So we have, looking to the left eye doesn't abduct in any up or down gaze. It can't abduct. So we have a left 6th nerve palsy. The left eye I've graded here is -3 because it looks as if 75% of its action isn't working. And the medial rectus of the other eye is overacting. So we've got stage 1 and 2. Looking in the opposite direction, stage 3 would be an overaction of this medial rectus, and stage 4 would be an underaction of this lateral rectus. And that isn't present, so this patient only has stage 1 and stage 2 of the muscle sequence. This patient was also diabetic, and so it's the same patient 6 months later, now has full abduction, and there's no longer overaction of the medial rectus. So things can go back to normal again. Okay, so I'm going to just stop for a second and go on to a video which I've got of the eye movements.
Usually the one straight ahead is, I think this one is it.
So I'm just going to play it again so that you can do it. You can have another look. So this is a patient who's looking straight ahead. She's got a right eye looking at the camera and the left eye is turning in. She has a left esotropia. So we're asking her to look at the target and she says she doesn't know which one to look at because she's got double vision. Cover the right eye, left eye moves out. So she has a left esotropia. And underneath the cover, the eye goes in.
Usually the one straight ahead is, I think this one is it.
So left esotropia, and underneath the cover, the right eye is actually a bigger esotropia. When she looks to her left, the left eye does not abduct fully. And when I cover the right, it tries, it's almost there, but it still can't abduct fully. So we would call that a -2, limitation -1, underaction -2. And wherever she's looking down or up, the abduction is not present. Now, when she looks to her right side, there's a tiny esophoria. So there's hardly any deviation at all. So there's no problem with her right gaze. And her vertical muscles are symmetrical. She's just got an esophoria. Her inferior rectus and her superior oblique are working. Superior recti working in both eyes. She's got an esotropia. And looking down, her inferior rectus are working. She's still got the esotropia in the left eye. Okay, so I'm just going to run it through one more time. So she's looking at the camera. She's got a left esotropia. She's got double vision. She tries to join it together by turning her head to the left. And when I give her the target to look at, she actually finds it's double. She has a left esotropia, moderate left esotropia of about 20 diopters. And when we cover the left eye, the right eye is straight. So we know that the squint is in the left eye. So we ask her to follow to the left, and the left eye does not follow fully. It stops there. And when we're covering it up, it tries to increase a little bit, but it still is not full. So we call that a limitation. And she can't abduct her left eye looking up to the left because the abduction is still, the lateral rectus is still defective. She can look down, so her inferior rectus is okay, but she can't look out. Looking to the right, she can abduct her right eye, she can adduct her left eye. She's just got a little esophoria. Looking up to the right, she can elevate her right superior rectus and her left inferior oblique. Looking down to the right, she can depress with her right inferior rectus, left superior oblique. She can elevate both of her eyes. She still has an esophoria. And looking down, she has an esotropia in her left eye. Good. Okay. Can anybody write down for me what the 4 stages would be for a right sixth nerve palsy?